Good morning, everybody. Let's get going. Bonjour et bienvenue. Teenagers and young adults are a difficult population to care for, with low adherence to antiretrovirals and healthcare visits. Uninfected youth are prone to high-risk behavior, with amongst the highest risk for new HIV infections, particularly in some subgroups. Yet, research is not keeping pace in this population, and preventing new infections through testing, PrEP, and other means not enough of a priority. Today, we present a selection of abstracts that tackle these very issues based on retrospective, prospective cohort studies, cross-sectional studies, and as well as a randomized, double-blinded, placebo-controlled study. My name is Murli Praswani. I'm from Bronx Levin Hospital in New York, and together with...
Good morning. My name is Nyara Zomgodi. I'm from the University of Zimbabwe, College of Health Sciences Clinical Trials Unit.
Together, we are happy to chair this session. So let's start, Mavis.
Thank you. Our first speaker this morning is Dr. Andrew Medina Marinho, who is the head of research at the Foundation for Professional Development. He is a PI on 2 NIH-funded studies focused on STI testing of HIV-infected pregnant women, and home-based TB testing using the portable GeneXpert Omni device. He received his PhD in molecular biology from Caltech. Dr. Marino, thank you.
Good morning. Okay, so today I'm going to present to you some routine data that's been identified from our ongoing large-scale community-based counseling and testing program that we're implementing in South Africa. We believe that some of this data is actually revealing some insights into implications and potential synergies with PrEP delivery for young women. So globally, in 2015, approximately 1.9 million people became infected with HIV. Young women, or YW, aged 15 to 24, are at increased risk for infection. This is particularly evident in sub-Saharan Africa, where young women are accounting for 25% of new infections. In South Africa specifically, young women have a 4 times greater incidence of HIV than young men of the same age. And in certain recent HIV prevention trials, incidence has been as high as 5 to 6% per year in young women. Ultimately, implementing effective HIV prevention strategies is crucial to controlling the global HIV epidemic and identifying effective prevention strategies that women can directly control is key to decreasing age and sex disparities in HIV acquisition. HIV counseling and testing, or HCT, is the entry point for HIV prevention, care, and treatment programs. Traditionally, health facilities have been the primary providers of HCT services. However, community-based counseling and testing, or CBCT, is quickly becoming a major mode for HCT implementation. Facility-based HCT has not achieved the requisite high coverage in sub-Saharan Africa and will be insufficient for reaching the 90-90-90 goals of UNAIDS. This is likely due to a host of structural, systems, and individual level barriers. Such barriers include distance from clinics, operating hours, long wait times, confidentiality concerns, and low perceived risk, to name a few. Furthermore, such barriers have contributed to the disproportionately poor uptake of HCT services and facilities by men, adolescents, and key populations. Alternatively, CBCT has the potential to overcome many of these problems associated with facility-based testing. Specifically, CBCT has been shown to decrease barriers and increase uptake by priority and key populations. The relatively minimal infrastructure required for most CBCT modalities allows for easier scale-up of services. Furthermore, community-based testing campaigns can be tailored to the local HIV epidemic and the specific needs of the community. Finally, compared to those that test in health facilities, community-based testing has been shown to identify HIV-infected individuals earlier in the course of their disease. So we initiated CBCT services in July 2014 and reached full implementation capacity in September 2015. A combination of testing modalities are being employed, including systematic door-to-door home-based testing, near-home mobile unit testing, index patient trailing, workplace testing, fixed-site HCT, twilight testing for key populations, and a new innovative CBCT modality involving social franchising of testing services currently in a pilot phase. Following client testing, our programs support linkage to care for prevention services for those that test negative, and ART initiation services for those that test positive. This is a map of South Africa's 9 provinces. Shown here are the 13 high-burden, high HIV transmission districts that our CBCT program is currently being implemented in. Routine monitoring data from October 2015 through September 2016 were analyzed using descriptive statistics. Testing uptake was defined as the number of tests conducted in a particular district per 1,000 population, and the South African 2011 census data was used as the population-based denominator. The raw number of tests conducted stratified by age group and gender are presented here. As highlighted in red, more than 660,000 tests were conducted in the 1-year period since reaching full implementation. As highlighted by this red column, girls and women of all age groups represent greater than 50% of all testers. As highlighted in the red horizontal box, the largest number of testers were aged 25 to 49. This graph represents HIV positivity of women and men by age groups. As seen in the red curve, the prevalence of HIV in girls and women begins to diverge from boys and men between the ages of 10 and 14, with a peak prevalence of 10.5% in women aged 25 to 49. Ultimately, our CBCT data reflects that of the broader South African epidemic and is likely a good proxy for general population rates as documented by previous prevalence studies. So as I previously presented, the largest number of individuals presenting for testing were those aged 25 to 49. However, when calculating uptake per 1,000 population in each age group, we see that the highest uptake was actually occurring in those aged 15 to 24 years, with young women 15 to 24 having the highest uptake of any age group of either sex. When we disaggregated the 15 to 24 age group into 15 to 19 and 20 to 24, young women continued to have the highest uptake of HCT compared to other age groups of either sex. So to determine if the increased uptake by young women was consistent in all 13 implementation districts, we calculated the HCT uptake of women by age group per 1,000 population. As highlighted in the red column, in 12 of 13 districts, young women aged 20 to 24 had the highest HCT uptake compared to other age groups. In comparison, young women aged 15 to 19 had the second highest HCT uptake compared to other age groups in 9 of 13 districts, and the highest uptake highlighted in red in 1 of the 13 districts. Relative to other age groups, these findings are all the more robust when you consider how consistent they are regarding uptake by this age group in both rural and urban districts with very distinct sociocultural demographics. So, what are the potential implications and synergies of community-based counseling and testing for PrEP implementation? An increased number of countries are granting regulatory approval for PrEP. However, gaps in the PrEP cascade that will continue to impact implementation, scale up, and impact are awareness of PrEP by those at high risk, identifying high-risk individuals, screening high-risk individuals, linkage to PrEP programs and providers, interventions that support the prevention effective use of and adherence to PrEP, and the sustained retention in comprehensive PrEP care, including regular HIV testing and clinic visits. Given our findings, we believe that community-based counseling and testing programs may have a significant impact on the gaps relating to the identification and screening of high-risk individuals and linkage to PrEP programs and providers. To remind you, by definition, young women aged 15 to 24, especially in South Africa, are a high-risk group for which PrEP must be made available. Our CBCT programs did not implement any specific strategies targeting young women. However, young women aged 15 to 24 in our high-burden, high HIV transmission districts had a disproportionately high uptake of CBCT services compared to any of the other age groups of either sex. This suggests that young women find CBCT services to be highly acceptable and accessible. Second, by its very nature, CBCT acts as the very first screening step for access to PrEP by identifying HIV-negative individuals. Finally, as previously mentioned, young women encounter numerous barriers to accessing reproductive health services at traditional clinics. Leveraging community-based counseling and testing platforms and programs to provide access to and initiation services for PrEP may be an effective alternative to referrals to traditional clinics. Ultimately, if access to PrEP is to be scaled up and its impact on preventing HIV infections in young women is to be realized, innovative supply-side delivery platforms must be identified. We believe that CBCT platforms are an acceptable and accessible community-based delivery platform for PrEP services. Thank you very much.
Thank you very much, Dr. Marinho. We'll take a couple of questions. Could you kindly introduce yourself, tell us where you're from, and keep your questions short? So while I wait for people to gather up, guests to come to the microphone, Dr. Marinho, I do acknowledge that young women need a tailored approach, behavioral, structural, and biomedical. So in terms of identifying women at high risk, how exactly do you propose that this be done? Because with community-based testing, we're just identifying young women who are almost already infected. What about the other risk factors? Where do we find these young women?
Okay, so we got that question from a reviewer in NIH review panel. So by definition, the 13 districts that we're implementing this in are very high transmission, high burden districts that have a very high prevalence. So if you want to think about it from an environmental community perspective, unfortunately, most of the girls in this community would be considered at high risk by the definition of an environment.
Thank you. So I do agree with identification of hotspots. Yes. Thank you. Question there?
Thank you. Landry Tsage with UNICEF Regional Office in Western Central Africa. This study provides a great standpoint when it comes to using HTC as an entry point to identifying the negative before as soon as possible, and more importantly, to be able to understand what makes the positive more likely to have been infected. Can you elaborate a bit more about what were the risk factors for those adolescents, especially those 15 to 19, who were positive? Thank you.
Okay, so are you asking me in general what are the risk factors, or what are the risk factors in these particular communities?
In this study, yes. Did you look at the risk factors?
Okay, so this data was actually routine programmatic data. We have individual level data that we're still cleaning now, where we've asked some risk factor questions, but we don't have that information right now.
Thank you very much. I think we'll hear your question, then Dr. Marino can answer it at the end of the session if we still have time. So we can hear your question and we'll move to the next speaker.
Thanks, Dr. Marino. It's Peter Godfrey Fawcett from UNAIDS. It's a great to get 600,000 HIV tests done and so on, and it's a really interesting model. I was interested, you showed the differences by gender and by age group. You didn't focus so much on the different testing rates by different districts, and I noticed that Etiquette, which is the Durban metropolitan district that has the largest number of people, the largest number of HIV infections, also had one of the rather lower rates of getting tested. And so I just wondered whether you thought your model was more appropriate for the rural areas, or whether you can also use it well in urban places where HIV transmission is often greater, particularly amongst key populations and potentially PrEP users.
Okay, so I completely understand that question, and the amount of testing conducted in each of these districts was more about the amount of resources put in per district, and for better or worse, that was more a donor-driven issue so this was funded by PEPFAR, and so they obviously had particular targets per district, and so that was much more about, like I said, donor-driven targets than it was about anything else. So we can't, unfortunately, necessarily tease out yet if there are certain modalities that are better at identifying certain groups, types, risk factor level individuals.
Okay, thank you. We'll move on to the next speaker now. So, our next speaker is Jessine Meyer-Ruth. So Jessine is a medical doctor and health economist focusing on the economics of HIV interventions, and is an assistant professor at Boston University in the United States, and works at the Health Economics and Epidemiology Research Office of the University of the Witwatersrand in South Africa. Jessine?
Thank you. I'm glad for once I didn't have to say all these things myself. Good morning. Thank you very much for giving me the opportunity to speak today about a cost-effectiveness analysis that we did in South Africa to identify the right target population for PrEP. As you might be aware, around about October 2016, there were a mere 100,000 people on PrEP worldwide, most of them in the US. The UNAIDS goal, however, is to have 3 million people on PrEP by 2020. At the very beginning of 2016, we were tasked by the PrEP technical task team convened by the South African Department of Health to consider the cost and impact of offering PrEP to a number of populations. Sorry, this point is a little bit screwed up. We looked at offering PrEP to young women, aged 20 to 24, to adolescents of both genders, both male and female, 15 to 19 years, and to female sex workers. And in the first two populations, we also looked at the cost effectiveness, whether or not it would be possible for us to target people with a self-identification as being of high risk. So basically a self-selection of the high-risk subpopulation. We used for this an epidemiological impact model called TEMBISA, which is an HIV transmission model that is fitted to South Africa. We made a custom-made cost model to add the PrEP cost to that, and we compared the cost effectiveness of PrEP provision with the cost effectiveness of a large number of HIV treatment, prevention, and testing interventions that we had included in the South African HIV investment case. We assumed that PrEP would be scaled up linearly from 2017 over the next 2 years to a target coverage of 18% for young women and adolescents and to 95%, so very, very high target coverage for female sex workers. It's important when you look at the results to bear in mind a couple of the central assumptions regarding PrEP in TEMBISA, the model that we used. Firstly, TEMBISA is not, the PrEP component of TEMBISA is not stratified by adherence or effective use. The average duration of PrEP use after initiation is a mere 2 years, And for every year on PrEP, we assume that people go to the clinic and get prescriptions that cover only 11 months, and they interrupt PrEP once a year. We also assume that on average, PrEP reduces your risk of HIV acquisition by 40%. When it comes to the assumptions that went into the cost, we all know that we don't know what PrEP costs in routine care at the moment. So we built our unit cost of PrEP provision on the information that was available at that stage, or is still the only information available, from the first demonstration projects to female sex workers, the project TAPS, run by the WITS Reproductive Health Institute and LSHDM, as well as to MSM, run by ANOVA. Importantly, we assumed the lowest possible cost in our base case analysis for everything. So we assumed we would be having generic drugs at that stage. We assumed that PrEP would be provided by the lowest staff cadre in any case, so that is mostly counselors as well as pharmacy assistants with a little bit of nurse time just for the clinical exams. It includes the cost of demand creation and of targeting, especially those high-risk populations. We analyzed this from the provider perspective. The South African government funds 85% of the HIV response, and we costed the entire HIV program in any case. That allowed us to then look at the incremental cost effectiveness of PrEP as cost per HIV infection averted over a 20-year time period, over a baseline of the currently available HIV interventions at coverage levels that we held constant. So this allowed us to look at the ability of PrEP to avert HIV and then to reduce the cost for ART as a result, for example. When it comes to the unit cost of PrEP, as you will see, we differentiated it between populations because the cost of monitoring, especially screening for STIs, etc., is driven by different prevalence rates across populations. Young women also get an additional pregnancy test, etc. But the cost also differs between the first year, which includes a second or a fifth, actually, screening visit, as well as another HIV test at the beginning. So the cost of the first year is higher than every year thereafter. Be this as it may, the total cost per person on PrEP is around about $200, so $220 across the different populations for the first year and $200 for the second year. And just to give you some orientation, the cost of ART per patient year in South Africa is currently around about $300 US. So in other words, PrEP is not a cheap intervention. The highest part of the cost is actually staff costs. So most people think it's just giving out the drugs and perhaps a little bit of HIV testing, but more than a third of that cost is made up by staff costs, a quarter only by the drugs, another quarter by the HIV tests. So in terms of the impact of PrEP on HIV incidence, it's important to bear in mind that in terms of HIV incidence as well as mortality, which I'm not presenting here, we've bent the curve several times over in South Africa over the last decade already. So this is just the baseline, just us running the program that we currently have at the exact same levels of coverage, which would bring us to a kind of target incidence of around about 0.4% across the entire national population, basically, by around about 2020, which of course is high, much higher than the virtual elimination threshold, where incidence needs to fall below 0.1%. Now, what happens if we add PrEP to this? If we just focus on those last 20 years that we modeled for this exercise, you can see not much happens at all. So, regardless of whether we are giving ART to 18% of all young women, 80% of all adolescents, 18% of all adolescents, or 95% of female sex workers, incidence does not budge much. In terms of the incremental cost, so this is not total cost, just the cost that changes over baseline cost over the next 20 years. We see an increase in that cost quite dramatically in some cases, but with the exception of giving PrEP to all young women, so 18% of young women aged 20 to 24, where cost continues to increase for the foreseeable future, all other PrEP provision models would have reduced annual cost after some while. However, the only kind of subpopulation or model of provision that would result in actual cost savings over 20 years and only from 17 years onwards is providing PrEP to young women aged 20-24 who are at high risk of HIV acquisition. So in other words, not only is PrEP expensive, it's also not very cost-saving in the long term. So this, all these results are put together in one table. I'll talk you through it in detail. Firstly, we are looking at, over the next 20 years, of millions of people, of person years on PrEP. We are also looking at a total cost of around about 45 billion US dollars for 20 years of providing HIV in South Africa. Most importantly, and as we've seen, that cost will not go down in any of those scenarios. It will, however, also not increase by much. This might not mean a lot to anyone in the room who's not a South African taxpayer, because this is not your money. I can assure you it's mostly ours. However, in terms of the effectiveness, again, not much happens. So in terms of the thousands, 10 and 100,000s of HIV infections that we are expecting, the millions of new HIV infections that we're expecting over the next 20 years, none of those PrEP provision models will reduce it by much. The reductions are really between 1 and 4%. This then results in an incremental cost-effective ratios for those of you who've seen those things before that are actually quite high, and both for as cost per HIV infection averted as well as cost per life year saved. And the last one is relevant because that is the metric that we used in the HIV investment case and a modeling exercise using exactly the same methods that we run over the last 2 years, and that produced these results. So here we look at the incremental cost effectiveness of increasing coverage to the absolute maximum with each of those interventions. And as you can see from a just short glance, PrEP provision to any population or subpopulation is less cost effective than increasing condom availability, increasing male circumcision, increasing ART both at the then current guidelines of eligibility at 500 CD4 cells, as well as under universal treatment, and a couple of testing interventions. In conclusion, this means that targeting high-risk populations is similarly or perhaps slightly less effective than providing PrEP to all risk groups within the population, but targeting high-risk populations comes in at a much lower cost. Even though PrEP is relatively expensive per user year, successful targeting of high-risk groups can render it more cost-effective, or as we've seen in the case of young women between 20 and 24 years, it can become even cost-saving in the longer term. The longer term here means 17 years, so that's quite a while. This, however, is contingent on high-risk populations actually successfully self-selecting for PrEP, and as we know, this is currently still out for debate, whether that is possible. The implementation, in part of, as a result of our calculations, which also led to an actual budget calculation, PrEP was rolled out to sex workers as part of a sex worker prevention program that was launched in June 2016 by these illustrious people, including the deputy president of the country. PrEP for MSM and young women were made available through limited demonstration sites around about the same time. The decision with regard to a national PrEP rollout to young women is currently on hold and will be based on demonstration study data from those sites. The preliminary data from those sites, so that's collected over the last 12 months, is that the uptake in young women trumps that of MSM and female sex workers, something that we really came to as a surprise to everyone. So young women, depending on the site, have an uptake of between 36 and 98%. MSM currently stand around 19%, and I think it's only 4 demonstration sites. Sex workers also in a limited number of sites, but the uptake is only 7%. And that is of HIV negative members of those populations. Adherence in young women seems to be around 40 to 70% over various time periods, so that was at the last moment of analysis. The plans currently of the South African government are to make PrEP available to young women currently only in a number of high prevalence districts through firstly universities, then mobile clinics around schools, and later also covering ANC and family planning clinics. And this is the actual press release that announced the start of the PrEP program or PrEP provision to sex workers. This modeling exercise, as these things go, is prone to a number of limitations. If we knew the data for all of this, we wouldn't need to model. As I mentioned, we do not know the cost of routine care provision. We do not know what the demand or then the actual uptake is by subpopulation. We do not know if people will in fact come forward for PrEP provision because they feel they're at higher risk of HIV acquisition. We don't know what the adherence or effective use will be by subpopulation in the routine setting. Another big question that's in front of us currently is if it was possible to geographically target PrEP provision to a number of hotspots or high incidence subsettings, is it possible, but also would that be ethical? Which would, of course, reduce the cost dramatically and increase cost effectiveness quite dramatically as well. As a result of this, those projections and budgets will have to be updated regularly. I'm grateful to a whole bunch of people who committed data as well as time to this project, especially the entire Department of Health PrEP Working Group. Thank you very much.
Thank you very much, Dr. Maya Rath. Because of time constraints, we are going to skip questions. We are going to move to our next speaker, who is Dr. Grosso, Ashley Grosso, who is a research scientist at Public Health Solutions. Previously, she was a research program manager in the Center for Public Health and Human Rights at Johns Hopkins University. She's the founder of the AIDS Museum, a non-profit organization that educates about HIV through the arts. Ashley?
Thank you. My presentation is titled State-Level School-Based Sex Education Policies on Sexual Orientation Are Associated with Changes in Teaching about HIV Prevention. I want to acknowledge my co-authors, Dr. Marianne Chasson and Diana Bermudez, as well as our funder, the Robert Wood Johnson Foundation. I'll start with the background on sex education policies in the United States related to lesbian, gay, bisexual, and transgender, or LGBT individuals. I'll describe the sources of our state-level sex education policy and implementation data, as well as how we analyze this longitudinal data set. Then I'll present our findings, implications, and future plans for the study. These are the 10 states that have laws restricting what can be taught about sexual orientation in schools. Most are in the South, but there are some others. In 2015, 11 states had these policies, which was an 83% increase from 2014, when only 6 did. And since then, only 1 state has repealed the policy. These laws are sometimes colloquially referred to as no promo homo or don't say gay laws. These are some excerpts of some of the laws. In Alabama, Texas, and Mississippi, the schools must teach the laws of the state which criminalize same-sex sexual activity, even though the Supreme Court overturned those laws in 2003 in Lawrence v. Texas. Also in Alabama, Texas, and Arizona, teachers cannot say that homosexuality is an acceptable lifestyle. There is also some implicit equating of sexual orientation issues with STD risk. So in Arizona, they say that there are no safe methods of homosexual sex. Oklahoma says that avoiding specific activities, including homosexual activity, is the only method of preventing HIV. And in South Carolina, sexual orientation can only be discussed in the context of sexually transmitted disease prevention. In Florida, Illinois, and North Carolina, the language is a bit softer, but still discriminatory, talking about heterosexual marriage or relationships. This issue has received some coverage in the press fairly recently. When Russia's laws, similarly trying to not promote homosexuality to young people, came out, there was an opinion piece pointing out that the US, some states have similar laws. An article pointing out the HIV rate increase in Arizona also referred to these sexual orientation, sex education laws. And Equality Utah sued the state to try and repeal the law, and Since then, the governor and the Senate have repealed it. The reason that we think these policies are important is that their implementation may limit the sex education available to LGBT students and their heterosexual peers. This is part of a larger study examining the relationship between sex education policies, funding, and implementation, and the potential effects on youth risk behaviors and health outcomes. This presentation focuses on the laws and implementation. Our research question is, what is the relationship between state policies on sexual orientation and sex education and schools teaching about HIV prevention, human sexuality, and sexually transmitted disease or STD prevention? Our independent variable came from the organization STATISTICAL, which reviews state laws and regulations and publishes state profiles annually. The three dependent variables came from the CDC school health profiles, which are based on self-administered questionnaires completed by lead health education teachers in a sample of schools every 2 years. The CDC reports for each state the percentage of schools that taught about each of these three topics in a required course in any of grades 6 through 12. We considered some time-varying and state-varying control variables that were found in a prior study to be related to these school health profiles indicators, but none were related to both our independent variable and our dependent variables, so we're presenting only bivariate results here. However, we did, through using state and year fixed effects, control for unobserved time invariant state-level confounders and state invariant time-varying confounders. Our data were from even-numbered years between 2006 and 2014. We conducted ordinary least squares regression analysis using Stata. We also tried other statistical methods, including logit transformation of the dependent variable, with results in the same direction and level of significance. So we're presenting the OLS results for ease of interpretation. We also thought perhaps it would take some time between when a law was passed and its implementation, so we used a lag variable for 1 year and 2 years in a sensitivity analysis. As part of the larger study, we found that no other policies were related significantly to these teaching variables. So it didn't matter whether a state required sex education and how they had to talk about abstinence, contraception, or marriage. It didn't matter. It didn't seem to be related to the teaching about these topics. This shows the number of states with policies related to sexual orientation in sex education. By year, you can see in blue that there was a decrease around 2008, and around the same time, you can see in the other lines that there was an increase in teaching about these three topics. Later, between 2014 and 2015, as I mentioned, you can see there was an uptick in the number of states with these laws for some reason, possibly as a backlash to other rights that had been granted by the Supreme Court and other laws. We don't yet have the data for 2016 for the CDC school health profiles, so it's yet to be seen whether we'll see a corresponding decrease. The differences are stark when you look across states. You can see that the average percentage of schools per state that taught each of these topics across all years combined was higher in states that did not restrict how sexual orientation could be discussed in sex education compared to states with anti-LGBT sex education laws. When we look at both between and within states, we see that having a state sex education policy that was anti-LGBT was associated with decreases in the percentage of schools that taught these three topics, ranging from about 16 percentage points for STD prevention to over 21 percentage points for human sexuality. This is the regression table. You can see that our R-squared was relatively low. So there are other things out there that explain why teachers do or do not teach these topics, but not things that we were able to measure. Additionally, it's not shown here, but we did find that the results were similar when we used the policy from a year before the school implementation, but not 2 years before. So it seems to be a relatively narrow window in which the law affects change. And also we did this in the reverse direction, using as an independent variable the state policy the year after the CDC school health profiles. And those results were not significant, which may indicate that the implementation follows the policy and not the other way around. So to summarize, state LGBT sex education laws may increase reluctance of teachers to talk about these sex education topics in general, which could affect students of all sexual orientations, not just LGBT students. The data here only covered states that went from having an anti-LGBT sex education policy to not having one. So we'll see possibly in the next year what happens when a state goes from not having one to adopting one. There are some limitations to the research. CDC school health profiles are only published if the number of schools that responded to the survey is of a certain number, 70%, so that they can weight the data. So the number of states with missing data ranged from 2 to 16 per year, and we're considering how we might do some multiple imputation or other methods to deal with that missing data. Also, teachers may be reluctant to report that they're teaching about human sexuality if they're in a state with these restrictive policies. But this is telling in and of itself that possibly there's not a correlation between the laws and what's actually being taught, but there is a correlation with what teachers are willing to admit that they're teaching. The CICAS data differ from some other categorizations, such as those by the Guttmacher Institute, and we chose CICAS because it had a pretty broad definition of policies that were anti-LGBT. Because we have a large number of policy variables that we considered and implementation indicators, there's a possibility that our results are significant due to multiple comparisons. But because the dependent variables were all similar in the same domain, we're a bit more confident that our results were not just due to chance. Additionally, this fall at the North American Forum on Family Planning, we'll be presenting data about the relationship between these laws and teen health outcomes, which also give us an idea that these results may be true. In the future, we'll also be looking at the relationship between these laws and youth risk behaviors and doing some structural equation modeling and multi-level modeling to examine the relationship between policies, funding, implementation, and outcomes further. These are the citations I mentioned for the potential control variables we considered. And with that, I'll conclude. Thank you.
Thank you very much, Dr. Grosso. Any questions? So perhaps allow me to start. Dr. Grosso, you've highlighted states with restricted or anti-LGBTQ policies. Are there any policies which require someone to speak positively or to be pro-LGBTQ?
There are. The Guttmacher Institute does report that 9 states have policies that require information about sexual orientation to be taught in an inclusive and non-discriminatory way. But we did not find a relationship between those positive policies and these implementation outcomes yet.
Thank you very much.
Thank you.
Our next speaker is Sarah Wood. Sarah is in the field of adolescent medicine and is an instructor at the University of Pennsylvania. Her research interests include identifying strategies for increasing antiretroviral therapy uptake for HIV treatment and prevention among adolescents and young adults.
Thank you
Sarah?
for the opportunity to present today. I'll be presenting data from a retrospective cohort study examining the potential for HIV transmission among adolescents and young adults receiving ART. So by way of background, in the United States, while adolescents and young adults are disproportionately infected with HIV, they face a number of disparities along the HIV care continuum. Importantly, when we look at the final stage of virologic suppression, we find that youth are less likely than older adults to achieve a suppressed viral load. And this is important because we know that virologic suppression translates not only into a dramatic reduction of disease progression, but also can eliminate the risk for transmission. However, HIV transmission does not occur with viremia alone, but rather at the intersection between viremia and sexual behavior that can potentiate HIV transmission, namely condomless or PrEP-less sex, or sex in the setting of an STI that can increase genital tract inflammation and viral load. When we think about making treatment as prevention work in this population, we then need to identify modifiable risk factors for intervention at this combined outcome of sexual behavior and viremia. While in risk factor analyses, we often focus on individual patient characteristics, it's also important to think about the role of structural health systems factors, such as insurance. While insurance has been shown to increase ART coverage and retention in care and decrease the time to STI testing and treatment, its role in transmission risk is unknown. For our international colleagues, a little bit of background on coverage for people living with HIV in the United States. Coverage typically takes one of three forms: private insurance, which is provided through an employer or purchased through a marketplace; public insurance, such as Medicaid or Medicare, which is age, income, or chronic disease-based; and lastly, coverage provided through the Ryan White Health Access Plan. Ryan White is a federally funded program which acts as the payer of last resort for people living with HIV and reaches more than half of the people living with HIV in the US, either through funding directly to clinics to provide care to those who are un- or underinsured, and also through the AIDS Drug Assistance Program, which provides universal access to antiretroviral treatment to those that are enrolled in its services. So the objectives of the current study were to identify the proportion of antiretroviral treated youth with high HIV transmission potential, which we defined as coincident viremia and STI, among a US cohort from 2002 to 2015. And secondarily, to determine the associations between insurance coverage, retention in care, and high transmission potential at all clinic visits during the study period. Our cohort included youth who were HIV positive and ART treated, aged 13 to 25, and receiving care at CHOP during the study period. And our data source was the AI cohort registry, which contains all patient data from clinic visits, all missed visits, and all laboratory values during the study period. We defined high HIV transmission potential as time concurrent viremia over 1,500 copies per ml, the threshold to transmit that has been previously identified in heterosexual studies, with log transformation of all viral loads. And our surrogate marker for sexual behavior was incident bacterial STI, which we defined as any of the following after the first visit: a newly positive nucleic acid amplification test for gonorrhea or chlamydia, a newly positive RPR, fourfold rise in titers, or failure of titers to decline appropriately after treatment. Our primary exposure was insurance coverage, which we dichotomized as covered versus uncovered. In our primary analysis, we considered covered public access insurance, private insurance, but we also included Ryan White pharmacy-only coverage with the hypothesis that since people could get access to antiretroviral coverage, that could therefore drive down their transmission risk, versus no medical or pharmaceutical coverage. To test that our findings would be robust to different definitions of coverage, we performed a secondary analysis in which we considered the Ryan White's pharmacy-only coverage as uncovered. Additionally, in our model, we had to consider retention in care. There can be a time-dependent confounding relationship between insurance and retention, wherein those that are insured may be more likely to be retained in care. Conversely, those who are retained in care who have continuous access to case management services may have an increased probability of being insured. We measured retention with a continuous time-varying variable of a visit adherence ratio, which was the total visits completed over the total visits scheduled at a given visit. Additional model covariates included demographics and baseline STI, which we defined as a history of STI at or before entry to HIV care. Our sampling frame included all visits with viral load and/or STI testing after ART initiation, and in bivariate analysis, we compared subjects with at least one episode of high transmission potential versus those without. And in our multivariable model, we used an inverse probability-weighted marginal structural model to adjust for baseline demographics, STI, and time-varying retention and care. So our results. There were 240 subjects who met our eligibility criteria and contributed over 2,600 visits during the study period. We first looked at any transmission risk, so any viremia over our threshold, any STI during the study period. And what we found was that the vast majority of patients, 73%, had at least one transmission risk. 21% had at least one episode of viremia, but no STI. 27% had at least one episode of incident STI, but no viremia. 8% had both STI and viremia at least once, but these were non-concurrent in time. And 17% had at least one episode of time-concurrent STI and viremia, therefore meeting our definition of high HIV transmission potential. When we look at the characteristics of our cohort, and I apologize, I don't have a pointer here, we can see that overall it was predominantly African-American cisgendered men with behaviorally acquired HIV, and nearly 50% had a history of STI at or before entry to HIV care. However, when we looked for differences between the 200 who had no episodes of high transmission potential and the 40 who had at least one, we found no statistically significant differences. We then looked at the distribution of insurance coverage over those over 2,600 visits in the cohort. 59% were covered with public access insurance, 18% by private insurance, 16% had no coverage, that's no pharmaceutical, no medical coverage, and 7% had Ryan White-only pharmaceutical coverage. So for the results of our inverse probability-weighted marginal structural model, looking at the impact of insurance on transmission potential, after adjusting for retention and care, race, age at and time from ART initiation, gender, and baseline history of STI, we found that insurance reduced the odds of high transmission potential by over 50%. And again, this is insurance including pharmacy-only Ryan White coverage. The only other statistically significant variable in the model was baseline STI, where those who had an STI at or before entry to HIV care had a threefold increase in the odds of high transmission potential across clinic visits. We then performed the secondary analysis where we considered Ryan White pharmacy-only coverage as uninsured. And in that model, you can see that while it appeared that insurance coverage was still protective, in fact, it no longer met statistical significance. However, there was minimal impact on the point estimate for the association between baseline STI and high HIV transmission potential. As with all research, we have limitations to our data. We used STI as a biomarker, in part to avoid the bias that can be associated with self-reported condom use. However, this ends up with a very conservative model, and we likely underestimate the true prevalence of high transmission risk in the population. Marginal structural modeling can manage time-varying confounding, but only can look at a dichotomous treatment effect, so we did not model a multi-level categorical variable for insurance. Our data represent observational data from a single US cohort and may not be generalizable to the population of youth living with HIV in the US at large. And finally, there always may be unmeasured confounding from variables we did not capture in our data sets. So what are our conclusions? Namely, that insurance, when defined including antiretroviral coverage, protected against high HIV transmission potential. We also find that STI at or before entry to care was a risk factor for future transmission. And what are the implications here? Number one, that we need integrated adherence and sexual health services for youth living with HIV, with a particular emphasis on those who come into care with an STI. But I want to also point out that while the framing of this abstract is on transmission risk, this has important implications for treatment as well. Each of these episodes of STI or viremia represent a preventable episode of additional morbidity, both medically and psychosocially, in the youth living with HIV in our population. So our data suggests that universal antiretroviral coverage is critical not only for the success of treatment as prevention, but for the health of youth living with HIV as well. I'd like to thank my co-investigators, my research team, my funding sources, and most importantly, the patient and staff at the Adolescent Initiative Clinic at the Children's Hospital of Philadelphia. Thank you, and I'm happy to take any questions.
I have a question. Sarah, you considered viremia, chlamydia, gonorrhea and RPR titers, or
Correct.
syphilis. I'm just curious, why didn't you include genital HSV or herpes in this equation?
The reason we didn't include genital HSV is the way that this is all clinically abstracted data, and so we were unable to determine if it was incident HSV or HSV recurrence, and because we were specifically looking at incident STI, we limited to bacterial. So we've modeled it with the viral STIs included as well, and there's not a whole lot of difference, although that prevalence of transmission potential does look higher. But again, it was that incidence versus incident STI versus recurrent that we weren't really able to tease out in our data with the HSV cases.
Right. And secondly, how did you handle treatment? One subject could have more than one episode, right? So did you look for documentation of treatment of gonorrhea or chlamydia?
So we have, basically, the way that we looked at the data is, I can say as a clinical provider and because of our reporting requirements in Philadelphia, essentially everyone who has positive gonorrhea or chlamydia is treated in the cohort. So we did, in each episode of incident gonorrhea and chlamydia, we treated as an individual incident gonorrhea and chlamydia. So people could have multiple episodes of incident gonorrhea, chlamydia, and even multiple episodes of incident syphilis within the cohort.
Hello. Philippe Amselati, IRG, France, Côte d'Ivoire. I'm not familiar with US. What is the cost of antiretroviral therapy with insurance or without insurance?
So in the United States, antiretroviral therapy, the cost without insurance is basically completely cost prohibitive. It depends on the regimen, but anywhere from 10 to 20,000, possibly less for something that's all on generic. I mean, the key takeaway point here is that in the United States, no one should actually have to pay for their antiretroviral therapy because the Ryan White program acts as a safety net. So even if you're insured and you have a high copay, if you have Ryan White coverage, it will cover your copay. If you're uninsured, Ryan White will cover your antiretroviral therapy. The difficulty is for people to continuously receive Ryan White funding, they need to reapply, and it's state administered, so that changes state to state. In Pennsylvania, where this data is from, typically patients need to reapply every 6 months for their Ryan White funding. So those who fall out of care, who no longer have Ryan White coverage, are not going to have access to antiretroviral therapy. So that's why that retention and care piece was so important in the equation.
Thank you for your presentation, Anatole Melanie Hansen, London. I was wondering if you were looking at Trichomonas vaginalis as well, since that's an important STI amongst the black community in America in particular.
Yeah, so I think that's a great question. We do have some data about Trichomonas. The reason that we did not include it here is because we actually have very few women in the cohort. So we're about 90% men, and we were not doing either asymptomatic or really symptomatic screening throughout the study period. So we felt that we would really be underreporting the burden of trick because we weren't routinely testing men.
Okay, and a follow-up on that is the chlamydia and gonorrhea, was it just urethral then, mostly in the men?
No, this is mostly rectal. So we test all 3 sites every 3 months, rectal, pharyngeal, and urethral. And I would say that the majority of our infections are rectal.
And finally, those 40 people with at risk of transmission, how many of the partners were then seen and tested?
So that's a great question, and that's not data that we're able to capture in our database because we only have data from the youth living with HIV and not their partners. We do have a very intensive partner services program through the Department of Health in Philadelphia where essentially anyone who is a new positive is enrolled in a partner notification program. Thank you.
Thank you very much. Our next speaker is Dr. Brendan Morn Brown, who is an interdisciplinary social scientist with expertise on the social and behavioral determinants of HIV risk, HIV stigma, the uptake of HIV prevention and treatment services, as well as behavioral economics. Brendan.
Good morning. This was collaborative research with colleagues from HERD, York University, Epicenter AIDS Risk Management, and CAPRISA. So we know that HIV incidence is persistently high among young women in sub-Saharan Africa. Conflicting evidence has generated uncertainty about the role that age-disparate partnerships play in these infections, and therefore uncertainty about the value of risk reduction interventions within these partnerships. Two compounding factors suggest that age-disparate partnerships should increase HIV risk for young women. Firstly, age-disparate male partners are more likely to be HIV positive. Second, a range of studies have shown several riskier sexual behaviors that are characterized within age-disparate partnerships. On the other hand, there's the potential that current patterns of ART uptake among men may mitigate HIV infection risk within age-disparate partnerships. This is because HIV testing and ART uptake is positively associated with age. So age-disparate HIV positive male partners may be more likely to be on ART. We had two primary aims. First, to assess the association between age-disparate partnerships and HIV status among young women. Second, to examine whether the proportion of young women's partners who are HIV positive with a viral load of greater than 1,000, in other words, partners that pose an HIV infection risk, differs between age-disparate and age-similar partnerships. As a secondary aim, we also wanted to assess the association between age-disparate partnerships and HSV2, which is associated with an increased HIV infection risk among young women. We used data from the HIV Incidence Provincial Surveillance System, HIPS. The first baseline household survey from the study was conducted between June 2014 and June 2015 in two neighboring regions in KwaZulu-Natal, South Africa. The sample was drawn using random sampling of enumeration areas, then households, then one individual 15 to 49 years old per household, with initial sample comprising 9,812 individuals. Fieldwork included venous blood samples for HIV and HSV2 testing, and an extensive face-to-face questionnaire with the relevant data for this study on first ever and three most recent sexual partners, the start dates of these relationships, and the date and result of individuals' most recent HIV test. For our analysis of HIV and HSV2 among young women, we used the UNAIDS definition of an age-disparate partnership as one in which the male partner was 5 or more years older than the female partner. We created 3 binary measures of exposure to age-disparate relationships. The first identified women who reported that their most recent sexual partner was age-disparate. The second identified women who reported that any of her last 3 sexual partners was age-disparate. And the third identified woman reporting age disparity in any of their last 3 partnerships or in their first ever relationship. Importantly, partnerships that started after a self-reported HIV positive diagnosis were excluded, as these are unrelated to HIV infection. For this analysis, we used separate multi-logistic regression models for each of our age-disparate measures. We included control measures for potential factors which could be associated with the formation or dissolution of age-disparate partnerships, and we used weighted data and adjusted standard errors. For our analysis of HIV prevalence and viral load among young women's partners, we took all the ongoing partnerships that men reported with a woman 15 to 24 years old. Our assumption here is that these partnerships represent all partnerships involving 15 to 24-year-old women, and the partnership becomes the unit of observation. We created measures to identify male partners who were HIV positive, and male partners who were HIV positive with a viral load of greater than 1,000. We're interested in 3 categories of age-disparate partnering: men 5+ years older in general, partners 5 to 9 years older, and men 10+ years older, which are often termed intergenerational partners. Again, we use multiple logistic regression models to test the association between partnership type and HIV status and viral load of male partners, controlling for the age of the female partner. Again, the data was weighted and we used adjusted standard errors. Results showed that age-disparate partnerships were common. 32% of women reported that their last partner was age-disparate, and 42% reported that any of their first or last 3 partners were age-disparate. In terms of the ongoing partnerships reported by men, 26% of these partnerships were categorized as age-disparate in general, 19% involving a partner 5 to 9 years older, and 7% a partner 10+ years older. These graphs show HIV prevalence by partnership type among young women. All 3 graphs, with all 3 different measures, show that women who reported age-disparate partnerships were significantly more likely to test HIV positive. The last graph, for example, shows that women who reported an age-disparate partnership with her first or any of her last 3 partners, the prevalence among those women was 35%, compared to 22% of women who only reported age-similar partners. The added table shows the results were substantively similar when controlling for a range of factors. For each of our age-disparate measures, the odds ratio was around about 1.5 for the age-disparate variable. In the column I add to the table now, we see very similar results for HSV2 by all age-disparate measures. Young women who reported age disparity were significantly more likely to be tested HSV2 positive. In terms of HIV prevalence and viral load among young women's partners, the first graph shows that the age-disparate male partners were significantly more likely to be HIV positive with an odds ratio of 2.92. The second graph shows that age-disparate male partners were also more likely to be HIV positive with the viral load of greater than 1,000. These tables show the results by our 2 categories of age-disparate partnering. In the first table, we see that for both categories of age-disparate partnering, the male partners were significantly more likely to have HIV, with male partners 5 to 9 years old more than 2 times likely to have HIV than age-similar partners, and partners 10+ years old more than 5 times likely to have HIV. The second table, the second column, taking viral load into account, again we see that male partners in both categories were more likely to be HIV positive with a viral load of greater than 1,000. Importantly, the odds ratio for each of the categories was very similar. This suggests that the proportion of HIV infectious men in these 2 different categories were very similar. So overall, our results point to age-disparate partnering being associated with an increased HIV risk. This is consistent with a phylogenetic study, transmission network analysis conducted using a subsample of the same HIP study. It's also consistent with results from recent longitudinal data. These findings indicate that interventions to reduce HIV infection risk associated with age-disparate partnerships may be helpful to prevent new infections among young women. They also suggest and indicate that there is biological plausibility for the positive association. as age-disparate partners are more likely to pose an HIV infection risk even after taking ART into account. This finding underscores the importance of early diagnosis and treatment of HIV-positive men in age-disparate partnerships for preventing new infections among young women. Finally, our results indicate that current patterns of ART uptake among men may mitigate the additional risks posed by intergenerational partnerships. In other words, the distinction between different types of age-disparate partnerships may be less relevant when considering the biological risk posed by age-disparate partnerships for young women. I'd like to thank HIPS for data access and the HIPS study funders and investigators, and to all the households and individual study participants, and all the HIPS field and office staff, and all the lab staff. Thank you. I'm also happy to take questions afterwards to give my colleagues time to present.
Thank you very much for that consideration. So we'll move to our next presenter.
Our next speaker is Catherine Bungie. She's an assistant professor in obstetrics and gynecology at the University of Pittsburgh. In addition, she's active in promoting the microbicide film agenda, conducting phase 1 trials of candidate films, and is serving as a safety physician within the microbicide trials network. Catherine?
Thank you very much. I'm really excited to represent the MTN-023 protocol team and share with you the results of our safety and acceptability trial of the dapivirine vaginal ring in U.S. adolescents. As has already been highlighted, adolescents represent a very vulnerable population and are disproportionately affected by the HIV epidemic. Among girls ages 10 to 19, AIDS is the leading cause of death, and in sub-Saharan Africa, as a previous speaker already noted, 25% of new infections occur among young women in this young age group. Clearly, a prevention tool that works for this young population of women is absolutely necessary. The good news is that the dapivirine vaginal ring has been shown to reduce a woman's risk of acquiring HIV in 2 large clinical trials. The ASPIRE trial found a 27% risk reduction across their entire cohort, which was 18 to 45-year-old women, and IPM's ring study found a 31% reduction. However, when stratified by age, this protective effect was really only evident in the older cohort. Among women who were 25 and older when they enrolled, 61% fewer acquired HIV in the dapivirine ring group compared to the placebo ring group. And in fact, those women who were 18 to 21 had no protection, and these were the women who also showed the lowest adherence. This impressive differential by age is actually what set the stage for our question, which was, is the ring safe and acceptable in 15 to 17-year-olds, and is there reason to be concerned about safety? MTN-023 or IPM-030, or Project iMatter as we came to call it, was a phase 2A randomized double-blind placebo-controlled trial of a dapivirine vaginal ring in 15 to 17-year-olds in the United States. It was a collaborative effort between the Adolescents Trial Network and the Microbicides Trial Network. IPM developed and supplied the vaginal rings that were used in this trial. There were 6 sites across the US, 4 ATN sites and 2 MTN sites. Participants were randomized in a 3-to-1 ratio to either a dapivirine ring or a placebo ring, and they were asked to use this ring for 1 month at a time over a 6-month time period. Key inclusion criteria are demonstrated here. Because it was an adolescent trial, we needed to get participant assent and guardian consent, and we only enrolled girls who were aged 15 to 17, healthy, HIV negative, had a history of penile vaginal sexual activity, and were using an effective method of contraception at the enrollment visit. Our primary objective was one of safety. We wanted to assess the safety of the dapivirine ring when inserted once every 4 weeks during a 24-week of study product use. Our endpoints were grade 2 AEs deemed related to study product and grade 3 or higher adverse events. Our secondary objectives and endpoints included acceptability, which we measured by participant self-report via a CASI, adherence, which was measured by the frequency of vaginal ring expulsions and removals, also by self-report, and pharmacokinetics, both local and systemic. We measured dapivirine concentration in the plasma and the vaginal fluid. Our exploratory objectives included adherence, specifically to investigate the association between the systemic and the local drug concentration, the residual drug concentration in the used ring, and self-reported adherence measures, and then also the vaginal microenvironment to describe the genital microenvironment over 24 weeks of study product use. This slide shows a schema of our study design and visit schedule. Participants came in for a screening visit, and if they were willing and eligible, they came back within 56 days for an enrollment visit. At that time, they received a ring, put it in the clinic, and walked out the door. We checked in with them 1 week later to make sure that they were doing okay by phone, and then asked them to come back at 2 weeks and then at 4 weeks for a safety assessment. After that point, they came in once a month or as needed until they had used the ring for 6 months, and then after study product use, we followed up with them once more by phone just to check in. At each visit, we did an AE assessment. We also checked adherence and acceptability. At 2, 4, 12, and 24 weeks, we collected blood and vaginal fluid for drug concentrations. And at each month, when the girls came in to get a new ring, they handed over their used ring, and we sent that ring off to measure the amount of dapivirine that was left in that residual used ring. That was left in that used ring, the residual drug level. So these are our results. We enrolled 96 women, girls. The mean age was 16. The majority of women were African American or Black. The median number of lifetime sexual partners was 3 across this cohort, with a range from 1 to 23 in this teen population. Almost half of the girls reported that they hadn't used condoms the last time they had intercourse, and 1 in 5 girls in the dapivirine ring reported that she had not used a condom during anal sex at least once in her life. Again, our primary endpoint was safety. We found no differences in grade 2 related AEs or grade 3 or higher AEs between the 2 study groups. We did have 10 product holds. 3 were due to pregnancy and 4 were due to adverse events. The adverse events that prompted study hold included 2 counts of PID, pelvic inflammatory disease, one girl with trichomonas, and 1 IUD expulsion. Importantly, none of these product holds were related to product toxicity. We measured adherence in 3 ways, and I'd like to present that data right now. We looked at dapivirine plasma drug concentration, dapivirine residual drug level in the used ring, and self-report. By using a cutoff of 95 picograms per milliliter, we found that 87% of the plasma samples had levels that were suggestive of adherence to study product in the day prior to the visit. And while the plasma gives us a good sense of what was going on the day before the visit, the residual drug level in the ring is actually what provides some insight into the month prior to that visit. 95% of returned vaginal rings had levels less than 23.5 milligrams of the dapivirine, which suggests adherence over the past month. And by self-report, 42% of the participants reported that they had never removed the ring except to replace it monthly. And when they did remove the ring, it was for brief periods of time. This is a spaghetti plot of the residual dapivirine concentration over time. The x-axis shows the study participation time. The y-axis, the adjusted concentration of the dapivirine concentration in that used ring. The red line is the 23.5 milligram cutoff that I mentioned in the previous slide. Below that, suggestive of good adherence. And what I think you can appreciate is that the majority of the participants used the ring consistently over the course of the study. Lastly, acceptability. We asked the girls a lot of questions. I'm only presenting a handful to give a glimpse into their experiences with the ring. We asked these acceptability questions at 3 and 6 months. When we asked the girls, did you find the ring easy to use or difficult to use, 95% of the time they reported that it was easy to use or very easy. The majority of girls reported that they found no physical discomfort because of the ring, that they weren't aware of the ring during normal activities or during sex. And when we asked about whether their partner was aware of the ring, 41% of the time they reported that the partner was never aware of the ring. And if the partner were aware of the ring, the majority of the time, not at all, or a little, the partner was bothered by the ring. And then lastly, we asked if you liked the ring, and they did. 93% of the time they noted that they liked the ring. In conclusion, the depivorine vaginal ring is safe and acceptable in 15 to 17-year-old U.S. girls. Both plasma and residual vaginal ring drug levels indicate high adherence. The consistency between the depivorine plasma levels and the residual depivorine levels in the used ring supports appropriate study product use. Looking forward to next steps, the depivorine licensure package has been submitted to the European Medicines Agency. The South African MCC and the FDA are to follow soon. Importantly, safety data among adolescents is required to support product labeling of the new prevention product in this at-risk group. And while our study certainly provides some of that safety data, MTN 034, the REACH study, is set to begin in Q4 of 2017. This is a phase 2A crossover trial evaluating the safety and adherence to a depivorine ring versus oral PrEP in sub-Saharan Africa. Of course, I'd like to thank our funders, without whom this research couldn't be done, and acknowledge a number of people, most particularly Kathleen Squires, our fearless leader and protocol chair, the amazing site staff and site leadership who got a difficult study enrolled and completed, and Lisa Levy from FHI 360, who was our organizational head. Most especially, though, I'd like to thank the guardians for their trust and the participants for their energy, their time, their commitment, and most importantly, their enthusiasm. Thanks.
Thank you very much, Katie, for sticking to time. I think we'll allow Catherine Gill to present, and then we'll take questions at the end of the three presentations. So Catherine is a medical doctor. She's an MPH candidate. She's worked in HIV treatment and prevention for 10 years, and her interests include women and adolescents. And currently, she's working on the depivorine ring project and oral PrEP projects.
So thank you to the conference organizers for giving me the opportunity to discuss the findings of the PLUS-PIL study. 4 landmark clinical trials in adults have provided unequivocal evidence that daily oral PrEP is highly efficacious in preventing HIV infections. However, very little work has been done with PrEP in adolescents. PLUS-PILS is the first adolescent PrEP study in a heterosexual population and a first in Africa. Given the scarcity of data for PrEP in adolescents, and as gaps in our knowledge persist, the goal of this research was to strengthen capacity to create new health policies and prevention programs that are truly responsive to the needs of this population. The PLUS-PIL study was an open-label demonstration project which looked at daily oral PrEP for HIV prevention among 150 male and female adolescent participants in 2 sites in South Africa. The primary objective of the study was to evaluate the acceptability, safety, and use of a daily regimen of oral PrEP as a component of a comprehensive HIV prevention package, which included HIV testing, STI management, risk reduction counseling, access to condoms, PEP, and referral for male circumcision. The secondary objectives were to evaluate the adherence to daily PrEP, to measure any change to measure any change in sexual activity, perceptions of sexual risk compensation, and condom use, and to assess study participants and their partners' perceptions on key issues associated with oral PrEP. The exploratory objectives were to quantify HIV incidence, explore the utility of dried blood spots, and the impact of biofeedback results as an adherence-enhancing strategy, and lastly, to explore the relationship between daily PrEP usage and sexual practices and behavior. Eligibility for the study included being HIV and hepatitis B surface antigen negative, being sexually active, and on an effective form of contraception. The study was designed as an open-label trial with the possibility of being able to opt in and out of PrEP. All participants went through a screening process, and if they met eligibility criteria, they were invited to enroll. At enrollment, all participants were asked to take PrEP as part of a comprehensive prevention package for at least 3 months. During the first 3 months, participants attended monthly clinic visits for adherence counseling, safety assessments, HIV testing, and plasma and DBS sampling. Participants who consented to receive drug levels were counseled at the following study visit. At the 3-month visit, participants were given the option whether or not to continue with PrEP. Those who opted out were followed up in the same way as those who chose to continue with PrEP. This opportunity to opt out or opt back in occurred at 3 monthly visits, and those who had opted out were invited to opt back in at the next visit. Both sites also provided a number of adherence strategies, including SMS reminders and adherence clubs and events. The study was conducted at 2 sites in South Africa, at the Desmond Tutu HIV Foundation in Masiphumelele in the south of Cape Town, and the Perinatal HIV Research Unit in Soweto near Johannesburg. Both sites have a long-established relationship with community stakeholders, highly experienced study staff, youth-friendly activities, as well as sexual and reproductive health services, and an active adolescent CAB. Both sites have worked together with the South African AIDS Vaccine Initiative and the HIV/AIDS Vaccine Ethics Group to develop resources that ensure that the current ethico-legal framework for adolescent involvement in research studies is implemented. Following a period of community engagement and general education about prevention packages, including PrEP, participants were invited to screen for the study. Parental or guardian consent and adolescent assent or consent was obtained prior to study start. Each site was responsible for developing their own documents and tools and translating into local languages. So screening for the study began in March 2015. In total, 244 participants were screened. Reasons for screen fails included not being interested in taking PrEP, not currently sexually active, being pregnant, or being HIV or hepatitis B positive. In total, 148 participants were enrolled by March 2016. 1 participant was exited in the first month when it was discovered that she was 14. Participants were followed for 52 weeks, and the last participant exited at the end of February 2017. So enrolled participants were stratified by gender, with 2/3 being female and 1/3 being male. The oversampling of women was to account for the fact that although oral PrEP is relevant to both genders, young women are more vulnerable to HIV acquisition in South Africa. Enrollment was also stratified by age, with approximately 2/3 of the cohort being 18 or 19. About a quarter of participants had completed their formal schooling, and 90% lived with parents or with family. The median age of sexual debut was 14 and a half, and most participants only reported 1 partner in the previous month. A quarter of the participants had a partner that was at least 5 years or older, 3% had engaged in transactional sex, and 6% in anal sex. About 1/3 of participants reported regular condom use, and 3/4 said they'd used a condom at last sex act. Half the participants had used alcohol in the last year, and 15% had used recreational drugs, mostly cannabis. 40% of the participants had at least 1 STI at screening. Safety was our primary study endpoint. Overall, PrEP was safe and reasonably well tolerated. About 10% of participants experienced a grade 2 or 3 side effect that was thought to be related to PrEP. These included headaches, nausea and vomiting, abdominal pain, diarrhea, and skin rash. 2 participants reported a grade 3 loss of weight. There were no abnormal liver function tests or creatinines. 18% of participants opted out of PrEP at 12 weeks, with about 1/3 citing side effects as the reason for stopping. A further 20% opted out at week 24 or 36. The prevalence of sexually transmitted infections was high at baseline, and despite treatment, counseling, and partner treatment, remained high throughout the study. The incidence of herpes was very high, at about 8% per year. There was one HIV seroconversion occurring on study in a 19-year-old woman who had stopped PrEP 24 weeks prior to diagnosis. PrEP adherence was initially good, but fell off over time and when visits became less frequent. This is evident from the graph with a steep drop-off between weeks 12 and 24. The same pattern was seen in adolescent MSM in the ATN 113 study. About a third of the participants persisted with PrEP, but what is not clear from the small, short-term open-label study is whether the individuals who did manage to stay on PrEP were also the highest at risk for HIV acquisition. So we used a mixed methods logistic model to understand the factors that were related to adherence. We found that age was a significant predictor of adherence, with younger participants being more adherent than older participants. This may be due to the fact that the younger participants had to get consent from a parent or a caregiver, and this could have led to increased support in taking PrEP. It is also evident that young women were not less adherent than young men. So in conclusion, adolescents in South Africa are still at high risk for HIV. Sexual risk factors are present, despite extensive education and other interventions. The Plus Pill study showed that a group self-selected themselves that seemed appropriate for combination prevention. PrEP was safe and reasonably well tolerated, although some stopped due to mild side effects. PrEP adherence was initially good, but fell off over time and when visits became less frequent, reflecting the fact that adherence to programming is notoriously challenging for adolescents worldwide. Also encouraging to note that young women were not less adherent than young men. HIV incidence in this cohort was low, although there was evidence of unprotected sex, as evidenced by the high herpes incidence. The study also offered an opportunity to engage on ethical norms in adolescent research. So South African adolescents need access to PrEP with tailored adherence strategies and augmented visit schedules. More research on the fatigue element is needed, and other less frequent dosing strategies may also be of benefit in the future. Thank you to the participants and teams at both sites, to the NIH for funding this project, and Gilead for providing the study drug, and to Sybil, Landon, and Linda Gale for great support. Thanks.
Great. Thank you very much to all our wonderful speakers. I think we'll have a few minutes for some burning questions. So I think I have a question for the two Catherines. The last Catherine, you spoke about the benefit of having parental consent in adherence. What about in recruitment? Did you face any challenges in recruiting adolescents requiring parental consent? Banki can start.
Thanks, Narato. Yes, is the direct answer. I think having, and I noticed that you also had the requirement that they had penile vaginal intercourse, and parental consent was a big obstacle.
So exactly the same. It was a difficult study to recruit for, and we've subsequently been back to our ethics committee to request parental waivers.
My question was going to Brennan, but it has gone out. I was looking at the masculinity, femininity identity, because I was talking of the disparity, age disparity. And according to the data, we did a consultancy with the PEFA project. We are looking at gender analysis in HIV. The men prefer young girls as part of their masculinity. And they normally thought if it was the first time, you don't need a condom because then you'll miss that sensitivity. Thank you.
Thank you very much for that comment and question. Yes, next, Irene.
Constance Mackworth-Young from the London School of Hygiene and Tropical Medicine in Zambart. And my question is to everyone who presented on PrEP studies. And I'm interested because we know that in adolescents living with HIV, that many of them talk about the impact that ART has on their bodies, on the shape, the size, fat distribution, their weight. And I was wondering if that was something that was looked at in terms of PrEP and the impact that PrEP might have on their bodies, and if so, what findings you might have about that.
So on our study, we did have quite a few complaints about body changes, mainly weight gain, but also at the same time weight loss. So it's difficult to know. I think a lot of participants started contraception at the same time, so it's quite difficult to tease out the side effects of the contraception and the side effects of the PrEP.
Thank you. Ariane?
I mean Liz.
Liz.
Thanks, Nirada. I'm Liz Montgomery from RTI International. Katie, I had a question for you about why you think your study sample was so much more adherent than the young women in Aspire, whether you had any reflections and comments on that, and maybe it was similar to what Dr. Gill was saying about the parents being involved.
Yeah, I think that definitely had a lot to do with it. All of our participants had parental or guardian consent. I also think it was a short study, and we were exceptionally selective in the teens that we were trying to recruit, trying to find the right participant who would, I mean, all study sites do that, I'm sure, but I think it was slow to recruit because we were looking for the right participants.
I had a question along those same lines. When you're testing an investigational product, you can't inform the participants that this is an effective method. So with the studies that have shown effectiveness of PrEP and Aspire now, did that inform the counseling that you gave to your participants? And is that another possible explanation as to why adherence was better in your studies than they were seen in the prior Aspire and PrEP studies?
For sure, that was a big issue, especially with parental consent, the fact that they would be exposing their daughters to an investigational product. And we didn't, it was a big topic in the IRB discussions about what the benefit to being in this study is, since it's an investigational product. These weren't particularly high-risk adolescents in the U.S., we thought. But in the end, I think it didn't really influence our counseling and our encouragement to be in the study. What we talked about more was being engaged in healthcare, getting STI testing, HIV testing, and counseling. So that was really the true benefit.
So I would agree. I think getting STI testing for our population was a great benefit.
Okay. Ladies.
Hi, I'm Natalie from the Thai Red Cross. My question's for Catherine. You talked about the problem with fatigue in the long run. So as PrEP is taken up more by youth around the world and it becomes more long-term, do you have any preliminary data or ideas about what sorts of things we would need to be investigating and what strategies we could do to reduce fatigue?
So I think that's a great question, and I think a lot of people are very interested in the answer to that. I think for us, we think that maybe bringing participants back more frequently than 3 monthly would help. Also, it does seem like after a little while, adherence is stable. It drops off at a point sort of between 3 and 6 months, and then it's stable. So I think there's work being done around what you can do at the drop-off time to sort of to help the adolescents through that, because then we know that they'll persist.
We'll take the last 2 questions. Please go ahead.
Okay, yeah, right, thank you. My name's Charlotte Watts, I'm from DFID. If I may, I wanted to ask Gesine a question. Gesine, I really appreciated your analysis because I think it was very useful alongside the enthusiasm and, the challenges that we know about PrEP, to think about it within a national budget and to think about how this might fit in alongside other lower cost prevention investments, which we just really can't stop paying attention to. My question was, in thinking about PrEP, and particularly PrEP targeting to women, did you explore opportunities to make cost savings by linking delivery to other reproductive health services for adolescents, for example?
Thanks, that's a very good question. So the PrEP costing that we did was pretty incremental because it's a lot of additional visits and it's also a lot of additional kind of tests that you only need for PrEP. We are now busy thinking about kind of adding other services into PrEP rather than the other way around. The only cost savings we could have there, I think, are really at the level of the staff costs. So you have a couple less minutes talking about PrEP because or about HIV PrEPs in general because you have already covered that, or about sexual behavior if you integrate it with family planning services, etc. But I don't think that will make it all that much more cost effective, to be quite frank. So operationally, absolutely. Cost effectiveness wise, the gaps are quite big to the next group of interventions. So I don't think that will save us much in terms of cost effectiveness.
Okay, thanks. Thank you. Last question.
Thanks. I also wanted to ask Gesine a question. Peter Godfrey-Fawcett from UNAIDS, and I apologise, I don't apologise, but we're responsible for that 3 million people on PrEP that you put up as a target. And I think, you did present, in a way, quite a pessimistic analysis of the cost effectiveness of PrEP in South Africa. And I just wanted you to talk us through some of the sensitivity analyses that one might consider. You considered a 40% effectiveness, despite the fact that when people are coming and choosing to take a drug, we think that the effectiveness could be quite a lot higher. You talked about the costs of the drug making up about a quarter of the costs. In the Thai Red Cross, they make up 2/3 of the costs of delivering in a PrEP service that's costed in Thailand. So I was interested that it's so much more expensive in South Africa. You talked about the ethics of not giving it to the highest risk districts, and yet South Africa is choosing to have the She-Conkers districts that are 22 specifically high-risk districts. And we know, of course, that if an intervention is quite expensive, as PrEP is, it costs 2/3 of the cost of giving ART, of course it's going to be expensive if it's given widely, whereas if you can find the people who are genuinely at risk, it may be much more cost effective. We take the example of the UK, where some of these same discussions are going on, that the general incidence amongst men who have sex with men is 1%, but in the PROUD study it's 9%, and if you can somehow target the people who are most at risk, the cost effectiveness changes dramatically. What that means is that you may not get very much impact, and I completely agree with you that at a public health level, the impact of PrEP may be less than you expect, but at a human rights level, in the country with the highest rates of HIV incidence in the world, in districts where you have enormously high incidence, with a pill that we know if you take basically stops you catching HIV, and for those people most at risk is almost certainly cost effective, why would we not be recommending giving it to those very high risk women in the highest risk districts, not because of the public health impact overall, but because it's cost effective and it would prevent them getting HIV. You showed us that you could stop 78,000 people getting HIV. So you said that's not many compared to the millions who would otherwise get it. But if I was the family of those 78,000, I would say thank you.
Absolutely. Luckily for all of us, decisions in South Africa are not based on cost effectiveness alone, on cost effectiveness full stop. So as you see, the plans for rolling out PrEP are well underway and are not being stopped by this analysis, and neither should they be, right? So I think the important thing with PrEP is, yes, it's expensive. It is not and will never be our most effective prevention intervention. I think we can all agree on that, and we will roll it out because it is an additional, arrow in our collection, and we can target it to people who simply don't use enough of the other interventions. So I think that's, we will be rolling this out. There's absolutely no point against this. There were a lot of questions rolled into that. I'll very quickly answer some of them. In terms of drug cost, this is the generic, assuming a generic product, which is actually not yet on the market, which comes in below the $70 that I found in the latest UNAIDS kind of recommendation on that. So it's a lot cheaper. The fact that it's still such a lot of the total cost owes more to the fact that staff in South Africa are paid a lot more than elsewhere, including in Thailand. So
sorry, thank you, Catherine. I think we can take the discussion offline. I would like to thank all our great presenters, and thank you very much. Have a good day.
Thank you all. Thank you.